Welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults through our content that informs, community that inspires, and courses that deliver.
Hey everyone, welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults. I'm your host, Nicole, and this is the State of the Sniff. In today's episode, we're going to be discussing the infamous PDPM. And I have a cast of characters here with me. I have Christina, the speech therapist. You've heard from her before.
Hi.
We have the infamous Suzanne, who you've heard me talk about, but you've never heard her voice before. Treat for you.
We really can't curse today.
We really can't curse today.
Hey, kids.
And we even have an extra dog in the house. So it is a wild crew to bring you this exciting information on PDPM. So let's get started. Okay, so in case you've been living under a rock for the past couple of months, PDPM, or the Patient-Driven Payment Model, is what's going to be happening in the SNFs in October, beginning October 1st, right on the dot, and that's going to be our new billing system. All right, so how each patient is categorized and how we get paid is off something called the case mix. So physical and occupational therapy have 4 major categories, and combined with the GG function, that's their case mix. So the clinical categories for PT and OT, we do share them: major joint replacement or spinal surgery, other orthopedic, medical management, and non-orthopedic surgery, and acute neurological. Now, speech therapy has 2 clinical categories: acute neurologic or non-neurologic. So, Christina, what are your thoughts on this breakup of neurologic and non-neurologic?
There are definitely many opportunities here to further clarify non-neurologic, because as we know, there are many patients who have a need addressed by speech therapy that may relate to some issues that are not considered an acute neurologic condition. So there are groups for SLP-related comorbidities, including things like laryngeal cancer, dysphagia, ALS, oral cancers, trach or vent, TBI, which I suppose at that point, if it was in the non-neurologic group, it would be an old TBI and the associated issues that may be occurring as a sequela. And then we also have a very broad category of speech and language deficits.
Those are like exactly the same thing, right? Everyone.
Yeah, everybody knows what that means. That being said, the grid kind of allows you to put like a yes or no or a plus or minus for these things. So I think kind of as we continue on, we'll kind of see how you're going to have pretty much a yes or no question. Does this occur? Answer to identifying these comorbidities.
And then, Sue, the new change with this is that nursing is also involved in the way that we bill. So nursing has some case mix groups too?
Right. So they are set up into 43 nursing rugs. Please don't I can't explain them all, obviously. That's a whole other podcast. But it is a case mix index related to their diagnoses. You can refer to much information on all the different diagnoses that count. So just as an example, if someone's on a ventilator, they're going to get 5 extra points in their CMI. Versus someone that's going for radiation is going to get 1 point. But they are getting a point for that. You know, people were sending them out on a daily basis for 2 weeks. They go to radiation. At least we know we're getting something for it.
It's expensive.
It's expensive. Osteomyelitis is low. Let me tell you some middle ones. Cystic fibrosis, MS, transplant status, those are getting 2 points. HIV is up on the top at 8, and any feedings, the say that word?
Parenteral?
Yes,
That's how I say it.
They get 7 points. So it's a whole mess of different point systems that allows that. But ultimately for us, it's not only what they come in with, but then how they present with their GG codes and their functional status. And then that throws them into the case mix group, giving them a letter. And then they combine everything. And then this computer spits out what the CMI becomes.
Yeah.
And then the higher the CMI, the more money that will be reimbursed for all the wonderful care we give to our clients.
Excellent. All right. So that being said, and I know we all understand exactly what just happened there.
That's a lot of information. You guys aren't looking at anything. We're looking at 15 pages in front of us.
It looks like a college study session going on here. The amount of paperwork we have around us trying to make sure we get you guys the right information here. I want to talk myths versus reality, but I think the big thing that everybody is excited about, whether we use excited as good or bad, is group and concurrent. I've seen a lot of Facebook conversation about everything's going to be group. I'm going to have to group all these people, group. So what does that look like? The actual group and concurrent rules.
So the most recent that I've seen is a group is 2 to 6 people.
Okay.
So have fun with standing 6 people up and doing something worth their while and getting them better.
Right. That's the most important part.
Yes.
Like your groups have to be able to document that they're meaningful.
They have to be meaningful and they have to be related to what is wrong with them.
And incorporated in the care plan.
And incorporated into the care plan.
Yep.
The concurrent is 2 people doing different things, but 2 people doing it.
So Joe is on the new step, and Angie is doing
you're doing a balance activity
task,
with that person, but you're working with the both of them. What we don't know in our building is we still don't even know how the program looks on how we can even document that or track it. So overall, concurrent and group together is a maximum of 25% for the entire stay.
Could you say that again?
Concurrent and group together is the maximum of 25%. So it's not 25% group, 25% concurrent. They're combined, and it's a max of 25%. So take into consideration, you get someone that comes in, you put them in a group in the first 4 days of them being there, they get discharged the next day, go to the hospital, or their family comes in and demands them to leave, and now they have over 25% group because you didn't give them therapy on the first day, you did the eval on the second day, you did therapy on the third day, and now you did all group on the 4th day. So please watch what you do and make sure that patient isn't going anywhere in the near future as much as you can, because you will go over that 25% quite easily. And that's per discipline.
That's per discipline.
As far as I understand it.
Okay.
It's per discipline.
Okay. So that's, at least you don't have to be coordinating with each different discipline. Each discipline has their own. That gives you a little leeway, but you're right, 25% of a total stay can come up fast when you have unplanned discharges.
Yes.
Which happen.
Yes. Yes.
Another myth that I want to look at, myths versus reality. So we sat in on the ASHA, AOTA, APTA, and CMS webinar the other day, and they talked about myths versus reality. So now that concurrent and group is kind of tucked away. So some of the other myths that we saw. CMS is changing coverage requirements. That is not at all true, and I want to start there. According to CMS themselves, changes in the amount of therapy provided under PDPM as compared to RUG 4 or the manner delivered will trigger an additional review. They're not expecting, and nor should we clinically expect, someone's therapy need to change between September 30th and October 1st.
It won't.
They're still going to be the same patient. So if they are rugged at an ultra, you better still be treating them as that in the next week, or some serious documentation about why they all of a sudden don't need that much care. Definitely something you need to think about.
And CMS was very clear on the fact that they wouldn't even address the fact that people are asking about how many minutes you're giving someone.
Yeah.
And they said you should never have been told how many minutes you were supposed to see a patient. You're supposed to see the patient what they need. But in reality, we all need to have a schedule. We need to kind of have a guide of what we're doing. And hopefully our listeners have a manager that listens and will adjust it accordingly in the past, because there's going to be the same information coming forward, and then all of a sudden it's going to have to be adjusted because they don't want to staff people, the therapists, right?
Mm-hmm.
So now all of a sudden they're going to start listening, and it's going to just all mess up what they were doing versus what
They
they're
are
going to
doing.
be doing.
Yeah.
Be afraid of reducing your minutes.
Unscrupulous
Leaders of the world,
beware.
watch out.
All right. Another myth versus reality on the same thing on lines of profit. Max concurrent in group is required to maximize profit. No, the patients get the therapy that they need. And here's the thing with the documentation for the group. Your documentation needs to clearly show that the group that you decide to put the patient is safe, is efficient for what they need, and is giving the same level of care that they would have been getting without the group. So
And that they need a group
Yes.
compared to individual in order to do that.
Mm-hmm.
Yes, what the benefit of the group
What does
is.
the patient get out of that setting?
That has to be documented.
That cannot be met as an individual.
Not what does the therapist get out of lumping all their patients together. So
I get to bill for a whole other patient.
Nope.
Nope, not a thing.
All right. Another one that I made sure I write down was there is less PT and OT post day 21. And this is due to something called the variable per diem adjustment, which honestly, guys, is a mouthful. And I had trouble trying to understand what was going on here. But as Sue very nicely broke it down for me, all that means is there is a 2% decrease every 7 days after day 21 till day 100. And this is from whatever their original rate was, and that original rate, again, is based on their case mix score, and the case mix is a clinical category plus their GG scores. Am I right, Sue?
Yes.
All right.
Their original rate could be changed with an interim assessment, an IPA. That can change. You don't have to downgrade somebody. You can always upgrade. Well, I guess you would downgrade somebody. You don't have to send in an assessment and say how great they're doing. But I think what's going to happen is if we're treating someone with, a knee replacement, then they go out with, and they come back with a TIA or a stroke. Mm-hmm. Now things are different. Now they're a neurologic. We might be able to grab some additional money from that because of the additional care that they're now getting.
They have a higher need. They might not even have been on speech in the first place, so maybe they require speech after that.
Right. Now the days don't start over. Okay. You're still in that, whatever that window is. So if that happens at day 21 or say day 22, you still have the 2% decrease.
But it's 2% of a higher number.
But it's 2% of the higher number that they are now at.
Okay. That's good to know.
Yeah.
That's really good to know.
That's possible to happen.
All right. Now, this does not happen for speech, correct? You guys are immune from this variable per diem adjustment?
That's what I heard.
Mm-hmm.
Yep. Yeah, that's what
speech is speech is speech.
What they're saying.
Their numbers aren't affected.
The explanation was that under the current model, analyzing the amount of payments that SNFs are entitled to under Rug 4, the speech numbers tend to remain constant throughout the patient's stay. So patients who start on speech are likely to remain on speech through most of their stay at the very least. Patients who are not on speech in the first place are more likely to not remain on speech. So that would be something that doesn't change. And then the other factor is that they're likely to require the same amount of therapy time-wise anyway, throughout the length of the speech encounter.
Okay.
Can I ask a question?
Yeah, hope I know the answer.
So when in section O,
Mm-hmm.
the questions for speech, those 4 questions, 5 questions, whatever. The patient doesn't have to necessarily be on speech either.
Yes,
They
that is
just
correct.
have.
So let's say a patient
Section
who has a history of a CVA, underwent subacute rehab, a new baseline was determined, and let's just imagine for the sake of simplicity that the patient didn't have any communication or speech deficits, but perhaps they required a nectar-thickened liquid. It's been that way for a long time. It hasn't changed for whatever reason. That patient goes to the hospital for, someone give me an idea, for a knee replacement. And, oh gosh, I hope not. Okay. This unfortunate patient has gone to the hospital for a knee replacement. They required nectar-thickened liquids before this procedure. They continue to require nectar-thickened liquids after this procedure. Nothing about their knee replacement has cured their dysphagia. However, the patient is at baseline. They do not have a good potential for advancing that, and they are at their baseline. They're the same. Now, here's the thing. That patient would... in our scenario, that patient is not indicated for speech therapy. However, they continue to require that thickened liquid, which means that the facility has to give that to them. The nurses have to make sure that their meds are presented appropriately. The CNAs have to, or the restorative dining aides or whomever, has to properly prepare those nectar-thickened liquids using whatever thickening agent it might be. That patient would... fall under the classification of having a swallowing disorder under Section K in the MDS, which asks the clinician to check all that apply. The patient, A, may have a loss of liquids or solids from the mouth when eating or drinking. B, they're holding food in the mouth or cheeks, or they have residue in the mouth after meals. C, they're coughing or choking during meals or when swallowing medications. D, they have complaints of difficulty or pain when swallowing. Or Z, they have none of the above. Now, let's imagine that this patient doesn't experience those symptoms when they are getting their dysphagia liquid, their thickened liquid.
Or their crushed meds.
Which are probably, presented with maybe Q's or a nectar-thickened liquid wash or something to make sure all the residue leaves their mouth. Although that patient may not experience these symptoms when they get their dysphagia diet, their nectar-thickened liquid, they do have a swallowing disorder. And if they were not getting that special indicated nectar-thickened liquid, they would experience residue in the mouth after meals. They would experience coughing or choking during meals. They would complain of difficulty or pain with swallowing.
And the suggestion you received...
The suggestion we received is that you would check off their symptoms and their signs of their possible swallowing disorder. That would be occurring if they do not get their specially prescribed diet. So in other words, what does this special treatment prevent?
But you have to give them like a teaspoon of regular...
And we need to know. Right. We need to know.
Like we have to make sure nursing is... We have to know that they're crushing their meds. Like we don't know that. We know if they're on a modified diet. Mm-hmm. Yep. But all the orders say may crush meds if allowed, if needed or what have you. But we never know if meds are being crushed.
So practically what that means is that the speech therapist is doing a chart review. The speech therapist is doing a patient interview. The speech therapist is probably doing a bedside dysphagia assessment in order to find out, what does this patient need? What are we providing them with? How are we justifying the provision of this additional service, this nectar-thickened liquid, and this special medication administration for which we are getting reimbursed?
Right.
Yep. So do lots of swallow assessments, guys.
Yes. Thank you.
Yeah.
So another thing they mentioned, and I've seen a couple other places as well, is the fact that there's probably going to be more changes after October 1st. So just don't panic about the fact that there are changes and there's going to be more changes, and we're just going to keep doing our jobs, which is providing our patients the best evidence-based care possible.
Can I say one PSA about how
PSA away?
Yeah, about how it's really it might happen that PDPM isn't perfect, and as clinicians, we might manage to find some things that don't make sense, or some things that just aren't practical for the reality on the ground. Because, as I like to say, there are never enough clinicians in the room when decisions are being made. There are never enough. But the solution to that is to put yourself in the room. Reach out to your professional organization, to your respective reps within your organization that specialize in CMS, the liaison, whatever you guys call it in the APTA or the other one, which is called the AOTA, and let them know. And also, reach out to CMS, ask questions, give them feedback. They really, in all these seminars and all these things that we've read, and Suzanne has done more than anybody else in this room, except maybe Clover the dog, there are definitely many different avenues to reach out for help. And you can always find somebody who can at least kind of point you in the right direction. So,
personal question: how often do you write to Asha?
How often do I get angry?
Totally speaking from the only reason I'm pointing that out is because she actually is speaking from personal experience. I think every time something comes up, Christina's like, I'm going to talk to Asha about this, and then she does.
A lot of the times I'm just angry at myself because I don't know the answer.
I even say, go call Asha. Go find this. Can you ask them?
Yeah. And she does, and she actually does it, and then tells us what they said.
Well, and a lot of times you can check the internet first. So sometimes just because something isn't spelled out in the place where you think it might be spelled out, Google is your friend. So just look it up, or email your supervisor. Reach out. Reach out. There's always help. So anyway, sorry, that was
okay. I'm lost now.
Documentation.
All right, I want to talk about documentation, and I went into a little bit about group and how we need to document why it's important that our patient gets group, and it's not just we did group because we did group. So something that I've seen is the idea that things that are not so important could be given to restorative aids. And one of the things that really set my blood boiling was when somebody said range of motion or strengthening exercises. And I swear my head almost exploded, because guys, if you are doing strengthening exercises and you're not progressing them, you are wasting everyone's time. This is PT, OT, strengthening 101.
Speech too, you got to increase the load.
Right. So you already should be documenting why you need to do the strengthening exercises. So if someone in power or authority comes to you and says, we're going to give these exercises to a restorative aid, you're going to say, no, those are a very important part of my treatment. Here's my documented changes. All right? Write it down. If it's not written down, it didn't happen. And if it didn't happen, we can't prove that it's worthwhile. And if it's not worthwhile, PTs are not doing strengthening exercises. And honestly, people, what are we doing if we are not strengthening our patients? Mm-hmm. All right? There's literally a million other podcasts on this channel alone about strengthening and ways to strengthen and the whole old not weak philosophy. And so please don't let me see any posts in the Facebook groups about how you had to hand off your strengthening exercises to the restorative aids. You need to dig in. You can't even see me. I'm red and I'm fanning myself. Dig your heels in. And this is Sue. This is my manager saying, dig it in deep and fight, because that is your career and your license and your profession. And for the love of everything, you need to be doing that, not somebody else.
And the walking. So make sure you're walking your patients, because you're ambulating them and you're documenting their stride length, their speed, their gait speed, how that relates to falls, relate it back to something functional, because they will just take those patients, give them to someone to walk down the hallway instead of ambulate and instruct and protect them from
and teach
future
them
falls.
so that way they can be more independent.
Yeah. So just keep that in mind, because they're gonna come start taking your patients away and walking them down the hallway.
Well, and in the words of John Kane from CMS, who we got to hear on the webinar yesterday, he said that there is not a comparison between the service that a restorative aid provides compared to the skilled professional therapy that a licensed therapist provides. And he also said that a facility which hands off a significant portion of what ought to be skilled professional therapy to a restorative aid will, this is a direct quote, draw ire from CMS. So unless if you want Uncle Sam to impose ire upon you.
I think he also referred to them as the man at some point.
He did.
So if you want the man breathing down your neck,
Go for it.
Go for it.
Otherwise,
if you want to be able to stick up for yourselves,
have a job.
And have a job. Documentation is where it's at.
Strengthen.
Do your job.
Can I talk about students?
Yeah,
Yes.
Talk about students, because that was a question that came up too.
So,
and this is from where?
Okay, so section O of the, is it in the
third
RDS or the
chapter.
RAI? It's in the RAI.
Chapter 3.
Chapter 3. That might not be the proper order to look it up in, but I trust you to figure it out. Goes into some detail regarding the supervision and what that looks like.
The updated version.
The updated version. And this is something important. So there was a minor freakout that I also had, where there was some funky language in an older version of the updated RAI. Which basically said that professional therapists ought to be providing 100% line of sight supervision to students. That was not the framework under which we are even currently working. So everybody was like, whoa, why are we changing this? That has since been revised, and the version that is going live on October 1st more closely reflects our current state of affairs, wherein Medicare does not provide a minimal supervision in regards to what therapists have to provide to students. Our professional organizations already do a really good job of that, and we are able, for Med-A, and we are able to continue supervising our students in a manner that is appropriate for them, that allows them to start with an increased level of support and get more independent as time goes on. For example, ASHA requires a one-to-one supervision in which the speech therapist is not doing another activity other than supervising that student, not less than 25% of the time. So you are obviously providing more than that if you have a particular student that requires a little bit more assistance at a certain point in their internship. And then as that student progresses and becomes more independent, they are receiving not less than 25% of direct supervision. For Med B, the guideline requires that the therapist must be there in the room doing nothing other than supervising the student, who is the primary person providing intervention to the patient. You have to be there 100% of the time, no groups. The licensed therapist cannot be treating another patient. And the therapist is the person who signs the documentation. The student can also co-sign. So that's where we're at. If you have any questions or I said anything in a strange way, go ahead and read Section O for yourself. Honestly, do that no matter what. Everybody really should take responsibility for their own operations under this new RAI, because it's your license, and you want to be informed and to advocate for yourself. So check it out.
And then, Nicole, I'm going to just remind everyone that the therapist, we were talking about the interim assessment that's going to occur at the end of September. So this is going to switch the payment system from PPS to
PDPM.
Yes.
It's getting late.
So it switches from day, on that day. The MDS coordinators are going to be doing all these new assessments. As a department head in my building, I offered for us to complete the GGs for each patient that's in the building. My plan is that each therapist
and the speech case mix, because that's going to be
and the speech case mix is that the speech therapists are going to have to be out there. Well, the dietitians are also going to help. They're very helpful in that.
God bless them.
Yeah. And they're going to we're going to complete the GGs, and then we'll have someone manually enter them, either the MDS coordinators, myself, whoever has access to the MDSs. So we'll have that done, and I believe we have 3 days to have it completed.
And that's for everybody in the building?
Everyone in the building under Med A.
Okay.
There's all these other weird things that happens, like if they're going to leave, if they're leaving, and because you can't do a short stay. So if someone leaves on day
on like October,
like if they leave like October 1 or October 2, you can't do if they leave like October 2 or October 3, you can't do a short stay on them because there is no short stay. And it's all this weird stuff. Whatever. But
directors, go to your meetings.
They're gonna ask a lot of you, and you really need to plan the discharges. So work with your MDS coordinators. But yeah, those GGs and the GGs going forward, the GGs have to be completed within 2 days.
So do your GGs.
Yeah, so if someone comes in on a Friday, you can't wait till Monday to do the evaluation. You still have to evaluate the patient.
Yeah. See how that works. And then on the other end, make sure you do your GGs before you leave.
Yeah, before you leave the day.
Or you leave the day. Let's get that part done, and you can cry about the rest of it later. Are there going to be any? Exactly. Do you know if there are going to be any additional GGs, or like we're at where we're at?
We're at where we're at.
Okay, good.
Yep. So they actually cut out, right? We were talking about that. They cut out the oral hygiene.
Yeah. Because according to John, although it is an important part of patient care, it did not lend itself to a significant difference. So he really emphasized, there were some questions about that, I guess, that were given to CMS that he addressed in the webinar. And he said that, yes, like we know this is important. Don't worry. However, in terms of significant difference, whether or not it had any bearing on basically the reimbursement is what it boils down to, is that it just wasn't necessary to do that. So, But one less thing to write down. How often does that happen? You should definitely brush their teeth. And your own.
Yeah. Everybody brush your teeth.
And I remembered what I was going to say.
Yay.
So the dietitians can capture caloric malnutrition through grip strength that the OT does.
Huh.
They can utilize the numbers if the grip strength below whatever. I'm sorry, but I don't know what it is at the moment. But the dietitian is asking for that from our occupational therapists.
Yeah.
So we've made that a basic requirement on every eval to do grip strength. So the dietitian can capture that, which is captured then as a point on the overall assessment.
Interdisciplinary.
Yeah, you sang it much better than what I was going to say.
Yeah, I was singing it in my head the whole time you were talking.
You sang it out.
And I wouldn't have known that if my dietitian didn't say that to me. So I thought that was very informative.
Yeah.
Go on.
So, one other thing that I wanted to say is they kept stressing the fact that this is like a holistic patient assessment. And especially, I know that we've had conversations before about looking at each patient as an individual and looking at the whole patient and being more health-facing versus like sickness-facing. And I know that's like big conversations in the PT community. So this actually is kind of a step in that direction because here we are working with the whole team to try to address the patient, not just as like, okay, knee pain post replacement, but these other things that are going on in their life as well, and how they look from kind of all angles, from like a nursing angle and an OT and a speech. And I feel like that's a really good way to start making sure that like our return to community stuff is really more focused on like what the patient needs versus just like our little individual silos.
I'm hopeful that I will not have to send as many patients home who perhaps have had a CVA and they can walk, pretty far, but maybe they still have some skilled speech needs that, they have good potential to rehab in a subacute setting that provides the level of intensity that really isn't matched in the home care setting at this point. And healthcare and those nursing needs and those, other factors that come along with that. So I'm interested to see, where things go.
So I guess our final message is, there's a lot of change going on, but we're all kind of moving forward hopeful and with the knowledge that we really have to up our game on or make sure we continue to be at the level that we're at with our documentation and just making sure that, you're really putting in your notes what you're doing and that you are actually treating the people for what they need and not to what you're being told. I think that this gives us as therapists a good chance to really step up. And they did say that one of the big focuses of this, or what they were hoping were one of the goals of changing this system, was to increase therapist autonomy and use of clinical judgment. So take that, run with it, use your clinical judgment, and, don't be afraid about saying what you need and what your patients need, okay? It's all on you. So I want to thank Christina for coming back and Sue for finally being here with us. It's been excellent. And if you guys have any questions or concerns, you know that you can always reach out to me.
Thank you, Nicole, for all that you do.
Yay!
Aww.
Love you.
I feel special. All right, everyone. Have a good night, and I'll talk to you next month.
Thank you for listening to the Jaros Health Podcast. Go to jaroshealth.com to get the show notes for this episode and find out how you can join the Jaros community for free. You'll get access to our private Facebook group and the weekly Jaros Recap, where we share our favorite reads, podcasts, and any interesting conversations in the Jaros community that week. Once again, that's GEROS health.com. Thanks for listening.